Thank you, Mike. And thanks, Amber. That was a really excellent overview of the Affordable Care Act and what the implications have been for everyone. I do think there are a number of points that Amber made tonight that are really critical. There have been some very good things that the Affordable Care Act has done. It has actually increased access in a broad variety of ways. Many millions of people that wouldn't have had access to care before now have care. It has some problems, and I think there are some questions that everyone has. Many people have been adversely affected by some of the implications of the Affordable Care Act, whether it's a higher premium cost for you in the individual marketplace, or whether it's facing those higher co-pays and higher deductibles, so that when you do go to your doctor's office or you do go to the hospital, you find out that, oh, by the way, you have to pay for some things. For instance, if you're going to have eye surgery, or you're going to have hip surgery, or you're going to have some other major procedure, you have to pay up front in order to get that done. And many times that will cost you your entire deductible, like $4,500. This is kind of what it feels like to be in practice today. I've shown this slide before, and so some of my colleagues will forgive me for showing it again, but I think it does make the point that most people who went into medicine to practice went there because they wanted to take care of patients. They wanted to actually do something worthwhile. They didn't want to run a business necessarily. They didn't want to try and figure out how to fill out the paperwork, how to do proper referrals, how to make sure that you got paid for what you did, that you got an authorization for doing the test that you thought was necessary. I want to just take you back about 150 years. 150 years ago, medicine was pretty basic. Many of the things that we could do 150 years ago were very basic, meaning we had no antibiotics, we had no vaccinations, we could do some surgeries, but most of the time when you went to surgery, it was a life-threatening event, whether it was cutting off your finger or taking off your leg, or and most of the time you couldn't do abdominal surgery because there was no general anesthesia. What you had was the doctor there trying to do the best he could, trying to make the right diagnosis, and the truth is, much of the time all you could do was just, pray or whatever your mode of, meditation was, and hope that the patient made it through the night. When I left my residency, I have to apologize, I don't know where that biography came up and said that I've been in practice for 38 years. I'm old, but I'm not quite that old. I've been in Paradise for 34 years, so that's essentially the same, I guess. But I left my residency program in 1981 as chief medical resident. I thought I was a pretty smart guy. I came here to this community because I wanted to serve in a smaller community and wanted to be active and do all the things I was trained to do, which, thanks God I was able to do. But in the last 34 years, the practice of medicine, and you talk to any doctor in the room, the practice of medicine has been transformed. Amazingly transformed. One of the reasons the costs of care was so low in some of Amber's graphs were because there wasn't much care to give. When you were in the hospital, you might have been in the hospital 2 weeks for a pregnancy, or for a birth, but they didn't do much for you except just walk you around and feed you. Today, the reason we have people in the hospital and the reason they're so sick is because we are now able to take care of a huge variety of illnesses that have just escalated over the last 35 years because we're doing a much better job, and because the science of medicine has really dramatically increased logarithmically. So I want to talk about a few other things here in terms of the future, what the future might look like. Amber did this sort of at the end. I'm going to do it more at the beginning. There are a number of things that we've been working on for years. We've had the fight against cancer. We've had the fight against diabetes. We're still going to need to be doing those things. And sometimes what we've been doing more of than I would like to admit is trying to protect the status quo. Many doctors, as time has gone on, their revenue has decreased, and so they're trying to figure out ways, well, how can I do a better job of that? There has been an attempt to try and improve this fragmentation of care issue, and it is true that independent practice has taken a hit. Very, very few doctors today want to go into independent practice. That is, not be, many more doctors want to be part of a group where you have a set hours and you get a salary and those kind of things, rather than going into practice like I did, where you work essentially 12 hours a day, 15 days a week, and got one weekend off. I think what we're seeing now is increasingly the independent doctor is losing some control of the quality and patient safety, and there's no question that data control is really becoming an issue, as we are, even though we're moving more and more to the computer model. The data isn't interchangeable. We're clearly not at the place yet where we can exchange data freely across the whole system, like in Butte County. If I want to try and talk to someone like Dr. Potter or Dr. Sprague, I have to call them personally or fax them to exchange information. There's no way to do that electronically, at least in a seamless way. So many doctors are working more and enjoying it less. So I sat back and thought to myself, well, what would I like it to be like? If I could have healthcare the way I wanted it, and if I was God or King, how would it be? And I think it would be something like this, that the patient's care comes first, not the finances of healthcare, although the finances of healthcare are very important, not the computer, which is becoming a very difficult challenge for many doctors, and not necessarily physician reimbursement. But it would be a time when the science of medicine and the financing of medicine actually come together and are harmonious. Because we're making incredible strides in the science of medicine, but what we're challenged with is how do we pay for it, and how do we encourage young, bright, talented doctors and scientists to go into the biosciences to make the future even brighter than it is today. I think the key is that the science of medicine needs to be delivered at the point of care. I think there are tools that are developing there. And what I mean by that is, today we order something or we see a problem at the bedside or in the office in the exam room, and you try to fix the problem or try to address the problem, but there are insurers, there are people in the way trying to, sometimes it's managers of various sorts who are trying to get in the way and say, well, you can't order that scan or you can't order this test because it's not appropriate for this patient. However, they're not there in the room, they don't know the patient, they don't have the clinical information. So at some point we need to be able to deliver all of those algorithms at the point of service so that the person who's actually taking care of the patient can get the work done that needs to be done. And I think at that point then, the physician's decision for the patient needs to take precedence. We were talking a little bit about, population management and patient-centeredness and all these things. The question is, well, who makes these decisions? Who shapes the future of medicine? Is it philosophers of medicine? Are people in basic science? Is it clinical science or physician clinicians? Is it the government? Is it health plans? Hospitals, big pharma, economists, or is it consumers? Well, the truth is it's kind of all of these people. And so some of the things that we're talking about in terms of integrated care and population management and population health and chronic care management, all of those things are some group of people's ideas about how can we actually provide better care and decrease the cost in them at the same time, and yet still preserve adequate payments to hospitals, adequate payments to clinician providers like doctors and non-physician practitioners, so that they can actually afford to do the work. So I was thinking about this and looking at some information over the last couple of days. 8 ways that the Affordable Care Act is affecting us, and I think it's not just affecting us in these ways, it's affecting patients as well. As Amber already pointed out, this was the largest insurance expansion since 1965 when Medicare and Medicaid were initiated. And it's a historic change. So number one, there's a lot more covered service. There's increased preventive health services in the Affordable Care Act, and there's no out-of-pocket cost. That's a great thing. People get their blood pressure checked. People get mammograms. People get physical exams. These are very good things to have happen, and it's good for the society to have a healthier population. The benefit package, some people can say, I would say for myself, I probably don't need maternity benefits, but on the other hand, that is part of the enhanced benefit package. And that's one of the reasons why these exchange packages are a little more expensive. But a third thing is even more important, is that for the first time in the history of the United States, a person who is on the individual market has a guaranteed issue. That means they can go to an insurance agent and they can be sure that they can actually get insurance. That's a huge thing for someone who's not working, because prior to this, the only way you could be sure that you had insurance was if you had an employer who provided insurance. And if you lost your job, very quickly you lost your insurance. That's a very unstabilizing thing, and it's really not good for business, I don't believe, to have that kind of an uncertainty. The other thing is there's no lifetime or annual limits on coverage. So in the past, one of the common practices for insurers was if it looked like you were starting to incur very high costs, you were using the system a lot and using a lot of expensive services, they would send you a notice of rescission, meaning they were going to rescind your insurance policy. Sometimes that was because they were just being insurance company people and wanting to make more money. Sometimes it's because they thought you had actually lied to them on your application form 20 years ago or 10 years ago, whatever that case may be. But that cannot happen now under the new law, and that's a benefit for everyone, I believe. So there's more patients with coverage, more people with health insurance looking for a doctor. That can't be a bad thing for doctors or for patients, except that there's a mismatch. As Amber alluded to earlier, we're dealing with a physician shortage, and we're dealing with provider shortage, not just physicians, but non-physician practitioners as well, physician assistants and nurse practitioners. Medicaid expansion also has some implications access. There has been this large increase in the number of people who are enrolled in Medi-Cal, especially in California. But if you are a Medi-Cal patient and you're asking for a primary care doctor in Butte County, it's going to be a challenge because there are very few doctors who are accepting Medi-Cal for a number of reasons, and we can go into that. The question for the exchange, a little different issue, did they offer adequate rates to ensure that their people who they were enrolling in these plans would actually have coverage? And in fact, there's some evidence to show that they were intentionally not enrolling enough doctors and intentionally underpaying to try and keep their costs down. Now that's great for the insurance company, but if you're the patient, that's not great for you. Sometimes they've used these all products clauses, meaning that if you have a Blue Shield, if you're a doctor or a provider and you have a Blue Shield contract for, I shouldn't use Blue Shield, a health plan contract for a HMO product and a PPO product, and the health plan says, well, if you want to keep those contracts, you have to also take our exchange product. And I'll just tell you that the exchange in Butte County, I don't think this is proprietary particularly, but in my practice in primary care, I'm a general internist. I see a lot of geriatric people. I do a lot of Medicare and some private practice, some private insurance. When Covered California came to us and asked us, would you like to join the network for these plans? We said, well, sure. What's the conditions and everything? Well, currently with several of our major plans, we get paid less than Medicare to see those patients. So Medicare pays a certain amount of money. We get paid 90 to 95% of what Medicare pays for those plans, which is a surprise to some people. When the exchange came in, they said, well, actually, we were thinking about offering you 70% of your current rates. Well, 70% of 94% is 63%. It's not a sustainable rate because just on the business model, you have to have a certain amount of money to pay overhead, to pay salaries, to pay all the things that you need to do to run a practice. And frankly, at that point, my group just said no. It was interesting. I happened to be the president of the California Medical Association at that time, and I had an interview with an Eastern paper, well known in the business world, that interviewed me about this whole exchange rate, why there was a problem with physician enrollment in the exchange. And they had the idea that doctors in California were actually boycotting the exchange. And I said, well, that's actually not true. What's happening is doctors are making a business decision about whether or not this is a sustainable market for them. And in fact, when that quote came out in that paper, about 2 days later, I got a call from the head of provider relations for Blue Shield and, for one of those health plans, and actually for another one as well, that said, you know what, actually we should come talk to you because I think we can work something out. And actually, we now are participating in that plan. So the other thing that happened is there's higher out-of-pocket payments. If you are on the California exchange, you have an income of $45,000, the average silver plan will create a deductible of $2,500. That means you have to pay that money out of your own pocket before you can actually get any insurance services that are paid for by the health plan. The copay per office visit is about $45 to $65, and that's paid up front every time you go see a clinician in that system. Both patients and doctors have had to adjust to this whole process because people who were using a health insurance before were used to a very minimal copay, $15 to $20 copays per office visit, and a very low deductible, often $400 or $300, something like that. Not these sizable dollars. So it's been a, and I'll say this thing. There's something good about that, is that it gives you as a consumer, it makes you feel what it costs to actually get health care. Now, you can argue that feeling is too painful, and I can understand that, but this is a reflection of the cost of actually providing the care. It has been a benefit to primary care, and I can't say that I've always felt that there was a benefit to be primary care doctor, but that in the Affordable Care Act there has been. In Medicare, through this year in 2015, Medicare paid 10% additional to primary care doctors. Medi-Cal for 2013 and 2014 increased their rates to Medicare rates. Now that may not sound like much to you, but currently Medi-Cal rates in California are running approximately 50% of Medicare, and Medicare rates are Medicare rates. So that was a huge increase for primary care, but it wasn't for every doctor. It was only for primary care doctors. There was some advantage to being a patient-centered medical home in the Affordable Care Act. It did increase preventive medicine. It was a benefit to primary care because of these preventive medicine, wellness, and chronic care management codes that were built into the Affordable Care Act that gave additional incentives to provide that care. Number 5, as Amber alluded to earlier, it has resulted in consolidation of physician practices. Consolidation either in hospitals, large medical groups, or in IPAs. We're starting to see that a little bit in Butte County. It's not a huge process yet, but there are doctors who are consolidating around Enloe Hospital, Oroville Hospital, and Feather River Hospital. And as in the 1990s, hospitals are finding ways to acquire physician practices. Now, if you remember back in the 1990s, in the HMO days, there was a big trend in hospital acquisition, but in about 8 years, it went bust. Most of those doctors that were acquired went a separate way from the hospital. The problem is that today, the economy is so tenuous, I would say, that it may be more difficult for doctors to leave those organizations today than it was back in those days. So this is good and bad for customers. It's good for customers in the sense that, and consumers in the sense that larger organizations often will have more resources and more staff and more ability to give you service in some ways. it's bad for customers in a way that there is a tendency to get away from that personal feeling of your personal health care, that you're able to call up your clinician, provider, your doctor, your non-physician practitioner, and actually have a chance to talk to them and work through a problem, or go in and see them and sit down and talk to them with the problem, and they'll have adequate time to take care of you. That is not necessarily the way that treatment is happening today. Number 6, future payments are based on outcomes, and we all agree that it's important that we start looking at how, not just how much care we're giving, but what kind of care we're giving. And there's a number of ways this is happening. Accountable care organizations is it, we have all these words now and acronyms. I don't want to, I'm trying to not use all of them, but these are physician hospital organizations that work together to try and decrease costs and make care more efficient, so that the overall cost is less, and if they make the cost less, then both the hospital and the physician organization or the physician practices can benefit from that financially as well. Bundled payments are typically around one service. Typically, like for instance, I'm not saying it happens here in this community, but in some communities, hip replacements, for instance, or knee replacements are a bundled service. The Medicare will pay one fee for the whole thing. That is the doctor, the device, the hospitalization, the rehab, the whole thing. They'll pay one price for that. And if you're able to provide care for less than what that costs, then those people providing the care are able to split up the difference and make it more profitable, rather than just delivering more care. Patient-centered medical homes, we hear a lot about patient-centeredness, but this is another design to try and find a way to encourage care to be more coordinated, to make sure that when you go to the hospital, or when you go to the nursing home, or when you go to the emergency room or the intermediate care, that there's a process in place for trying to pull people together to make that, to coordinate that care. And the question is fee-for-service being replaced? Well, I think fee-for-service is always going to be here to some degree, because there are some services that you need to pay people to do the work for. You can't just say, well, we're going to pay you this global fee. I mean, there were stories back in the HMO days when you paid doctors a capitated fee, that they took the fee and didn't provide much service. That's not the idea we want to promulgate here. We want the care to be appropriate, and there are some things that the most appropriate payment model might be fee-for-service. But it doesn't, and definitely the Affordable Care Act encourages innovative ways to engage with your physician. So more and more you're going to see doctors offering texting, email, Skype services, telemedicine type services to be able to interact with patients, so that especially some patients who are homebound or who don't really need to be seen in the office, I think you're going to see more and more encouragement to use those innovative ways to engage with your physician. Recently, so the 7 things that there's going to be increasing penalties. If you don't do some things as a clinician, as a physician, you're going to be penalized. Up to now, if you prescribed electronically, you got rewarded for that. You got a little bonus for doing that. Now you're going to get a penalty if you don't do it. Patient quality reporting systems is a way we kind of keep track of some things. One of the reasons your doctor is there at the computer is trying to make sure all the report is done correctly. But PQRS was bonus before, but currently after 2015 is going to be a penalty. Meaningful use is the way people talk about whether the computer you use is being used appropriately. But if you don't comply with these implementation standards, there's going to be penalties for that too. So in 2015, 2016, 2017, until today, actually today is a historic day, because until today, these penalties would have been in place. As of today, because of legislation that was passed by the Senate on Tuesday, these penalties won't go into effect, and there will be more bonuses for your providers. And you'll see more consumerism in the marketplace. You'll see more rating of doctors And one of the more consistent sites is the physician compare website on that CMS is developing. I think it reflects an increase in people wanting to have a voice in how they get their care, and you'll see consumers doing more shopping and doing more intelligent shopping, and they're going to be demanding more information from us. So I too had a few graphs, and I'll try to get through these quickly, because this is actually, if you notice, this graph is actually the same graph. This is the Gallup graph that Amber put in early. You can see the same 18% peak. What I didn't have is the end of quarter, or end of the fourth quarter 14 and first quarter 15. So this dropped off from 13.4 to 11.2. So as a result of the Affordable Care Act, I think you can say that there's been a significant number of people get additional insurance coverage. Premiums have risen a little bit, but not nearly as quickly as we thought they would rise. And there's more plans participating than we actually hoped for in many places. This is a look at all of the states. Colorado having the lowest, that actually had a decrease in their change of a decrease in their insurance premium of 15.6%. California was a modest increase of about 0.8%, but it was up to 8.7% in Tennessee. So overall, what's happening is that the net effect on the federal budget is to reduce the deficit. You can see in March 2010, the Medicare budget was about $900 billion, and there was a base Medicaid payment here. That dropped in August of 2010 after the Affordable Care Act was enacted, and the Affordable Care Act Medicaid and exchanges were introduced. And then now in April of 2014, the overall cost in billions of dollars has decreased from a peak of $1.4 billion, I'm sorry, $1,400 billion to about $1,300 billion or $1,250 billion, something like that. Whether these trends will continue is really, this is maybe too early to tell, but it looks like some of the things that we were trying to do, that we're trying to be done with the Affordable Care Act are coming to fruition. One of the things we do know is that people who have insurance do better. So the all-cause mortality rate, when you look at people who have insurance from 2001 to 2010, all-cause mortality rate drops for all of those folks. I think that's just one of the things one of the reasons we think it's important for everyone to have health care. So our overall increase in healthcare costs is at a historic low. It's actually lower than this for 2012 to 2023. It's projected to be 1.1%. Historically, it's been up closer to 2%. In addition, we've seen some employer premiums increase, but not as much as we expected them to increase. And typically, winners, some of these slides, I'll have to say, are a little close. Winners outnumber losers. That is, among those who switched from a non-compliant independent plan to a compliant non-group plan, is the monthly premium amount you pay after tax credit for your current plan higher or lower than what you paid for your previous plan, or is about the same? 46% said it was lower. 15% said it was about the same. 39% said it was higher. So, it's 46% to 39% winners out over losers. So Covered California is our exchange here in California. In 2009, this was the projection of the employer group. This is what it was. The employer was 46%. The employers provided 46% of the insurance. Medi-Cal provided 19%. Medicare 10%. The uninsured were 19%, and individual market was only 6%. In 2016, we project that the employer group will drop to 35%. The exchange will increase will take up a lot of this other market that wasn't there before to about 22%. Medi-Cal will be a little bit larger at 22%. Medicare will be a little larger because of the baby boom at 12%. And the uninsured will drop from 19% to 8%. And this individual market will have gone away because it's part of the exchange. Or essentially gone away, there's 1%. So I don't think the ACA is going away. I think health plans, doctors, hospitals all change the way they're operating to comply with it. I think the consumers are getting used to it, and generally, I think it's more of a political issue than it is an economic issue today. I wanted to talk a little bit about just a couple of other things, and then I'll close. But I think one of the challenges for the insurance exchange is to actually make sure that there are adequate networks for people to be seen, and that's the challenge for both the exchange, Covered California, and for Medicare or for Medi-Cal managed care as well. As many of you know, you may or may not know, but a year and a half ago in Butte County, we moved generally from fee-for-service Medi-Cal to two major insurers, California Health and Wellness, which is a Centene product out of Missouri, and Anthem Blue Shield, and Anthem Blue Cross, I'm sorry, which is, a local company, or California and a national company. But the networks have historically been very narrow, and it's very difficult to get in, even when somebody's taking those plans, it's difficult to get in to see them. And I think that's primarily because we've got physician workforce issues. It was already pointed out by Amber that a large number of our doctors in California are already over the age of 60, and with all of these additional things, that Shark Tank I was showing you before, all those challenges make it less and less appealing for doctors to practice into their 80s or until they die, which is what many, many people did for years and years before this generation of doctors. We'll have to see whether this is able to make it a more effective, more efficient system and can attract some of those older doctors to stay in it. I do believe that there needs to be new delivery systems. I think it's important that physicians have an important part in leading that, because I don't care whether, it is important to have hospitals, it's important to have hospital employees, but you can't provide care without clinicians being there. And that's why I think it's important for them to be involved in the new delivery systems. And I think it's important for them to be involved in data ownership and exchange, because that also is going to be key to providing security and safety and ensuring that the data that's being used is appropriate. There are a number of things here. I've used this slide for other talks, but all I would just say is that it's increasingly important that we provide a safe environment to deliver the care, and that what we deliver is quality. Now, sometimes what the government calls quality, or what even an insurer calls quality, is questionable whether it really provides true quality of care or not. Most of us recognize quality of care when we actually are working with the hospital, working with our doctor, working with the nurse that works with us. We can tell when we're getting quality care. Some of those things are not measurable, but we do need to start thinking very carefully about safety, about a team approach, about systems approaches to managing care. And I just said more about control of the data. All I will say here is that in the Medi-Cal managed care, this is pediatrics, healthy families. The dual eligibles are people who have Medi-Cal and Medicare. There's a rural expansion, which increased expansion to over 138% of the federal poverty limit. And then there are those who are in that 138, that expansion from 88% to 138% of the federal poverty limit are also newly eligible. All of those folks are essentially being enrolled in Medi-Cal managed care plans, whether it's Centene or Anthem in our county. In more northern rural counties, it's Partnership Health Plan up in Shasta, Siskiyou counties. I think as a community, you need to recognize what a big problem the physician workforce problem is. It's very difficult to attract young doctors to rural counties, and we've got to find ways. Both hospitals, physician organizations, and communities need to work together to make our communities attractive to these young professionals. Most of the time, young doctors today are not marrying a person who is going to be a housewife, or a person who's going to be a house husband. They're marrying somebody who has a similar career. Civil engineers, electrical engineers, computer engineers, stockbrokers, many attorneys. You can you can name any profession practically, and they will be married to a doctor. But when you're trying to attract those doctors to a rural community, many times we aren't able to provide that employment opportunity for their spouse. So we need to provide not only those things, but we need to provide the right environment so that we can actually attract those young doctors to our communities and retain them for the long term. Because you and I, and I'm speaking personally here, but we're all going to need a doctor to take care of us eventually. And that's an important thing for our community to focus on. One of the things I will say about the Affordable Care Act is that it actually, for the first time that I can remember since I've been in practice, for the last several years, 3 to 4 years, healthcare has been one of the most hot topics to talk about that ever. In the 1990s, when we were talking about HMOs and Hillary care and that sort of stuff, it wasn't the same conversation. But today, I sense that just because of your interest here tonight, that communities are concerned, they're interested, they want to find ways to make healthcare work for them. And I think that's a very admirable thing. So with that, I think, I don't need to do this. I was just talking about health insurance exchange, health exchange, which is information exchange, so that people can talk to each other, so that there's seamless information flow. And I guess this is my last couple of slides. You can either sort of sit on the sidelines and act like you don't really care and you don't have an opinion about whatever happens to healthcare, or you can be Minutemen and get out there in the trenches and start trying to advocate and trying to find ways to make the healthcare system work more effectively for you. Thank you.